I won't keep you long. I won't stand between you and drinks and nibblies. I'd like to declare that I have no conflict of interest in this matter. I want to thank the staff of QASM, Sonia Faint, Kirsty Webb, Jenny Allen, Candice Poston. And some of you might not know that as well as looking after the Queensland Audit of Surgical Mortality, we also cover Northern Territory. Excuse me. This talk I'm going to divide into just 10 minutes, that's all. Our past, our present and our future. So QASM's history in May, we will have been going for 10 years, May next year. The audit is based on the Scottish model, SASM, which sadly is not working anymore. It was introduced in Australia 12 years ago in WA by Dr. James Atkins, and our first clinical director, many of you might know, Dr. John Cohen. In the early days of the audit, all surgical case forms were paper. I think I should tell you that all the surgeons here that from the 1st of January next year, all WA and South Australian forms are going to be electronic, that they're not going to have any more paper forms. So I could see that we will resist it, but we can't resist it energetically too long because there are lots of people in Queensland who will only use paper forms. We've always had good relations with Queensland Health. They've been very consistent with the funding. We've always had nearly all the surgeons for the 10 years. However, in January 2010, the college mandated for all surgeons must participate in an audit for their CPD compliance. So that means we went up to 100% participation. We've had all the public hospitals involved from very close to the beginning of the audit. It took about a year for them all to come on board. And the private hospitals were not all involved from the beginning, but once the Wesley Hospital signed on, all the others followed. So we have 100% of surgeons and 100% of hospitals, and that's pretty much the picture around Australia. We have a very committed staff, a happy staff. We've scarcely changed in 10 years. John North is our present clinical director, and he's been in charge of our little team for 8 years now. So what have we done in that time? We've presented 9 annual reports, which I hope a few people have read, 17 volumes of lessons from the audit that are very, very popular. People like looking at cases. We've run 6 seminars. We've produced so many reports, there are too many to count. We've also had lots of presentations. We've also lost count with them. Our research publications, we have 10 papers in peer-reviewed journals, and we were instrumental in developing the app for case note reviews that's presented by QASM. Now, our findings from our 10 international peer review journals are that our surgical case form information is valid. We checked our information against second-line assessment medical records, and we found very few discrepancies. We have found that for surgeons, as regards the assessors, any issues that could be classified as an assessment problem is the most troublesome area of clinical incidence. This could be pre-op assessments, post-op assessments. We have shown clearly that the oldest patients in QASM had received lower levels of care. We have shown that general surgical patients, these are all different papers, general surgical patients with a delay in diagnosis were at increased risk of complications. And we have shown that there is an age gap of 12 years between Aboriginal and non-Aboriginal surgical patients who died. I would now ask Peter Wysocki to talk to the general surgery papers that we wrote together. Peter?
Thanks, Therese. So this is just a brief summary of 5 or 6 of the general surgical papers that have been published with QASM data in peer-reviewed journals. So one was on patients with cholecystitis, patients who were treated medically. had the same number as those patients who were treated operatively with cholecystitis, but those who were treated surgically had a dramatically longer length of stay and therefore use of resources. With patients with appendicitis, the people who died with appendicitis had complex appendicitis, so most of these patients underwent a laparotomy. Almost half had a right hemicolectomy as part of their initial surgery. So this is a cohort with complex disease. In patients who died following cholecystectomy, the vast majority had emergency surgery. In half, there were no deficiencies of care identified by the reviewers. The most common deficiency that was identified was during post-operative management, which was in the category of failure to rescue, so failure to diagnose a complication or delay to respond to the complication. We're always taught we need to operate early for patients with a perforated peptic ulcer. And in fact, 3/4 of patients who died did have early surgery. So the speed of surgery isn't necessarily the entire answer. And interestingly, the people who had a delayed operation, as in not on the day of admission, they had significant comorbidities, or they did not have a typical presentation. So there were people who were asymptomatic, for example, or had minimal abdominal pain. We looked at patients who died following right hemicolectomy, and this may come down to reviewers rather than the actual care, but in patients who died after elective surgery, post-operative events were identified more frequently. But people who died after emergency right hemicolectomy, it was the pre-operative workup and assessment that was found to be, it could have been improved. And the most recent one, we looked at patients with malignant small bowel obstruction compared to non-malignant small bowel obstruction, and despite being younger, patients with malignancy, as we would expect, had a longer pre-operative admission and were highly likely to need anastomosis at the time of their operation, which wasn't really groundbreaking findings. I'll hand over to Therese.
Thanks, Pete. So the journals that we have been published in, we've had 3 papers in ANZ Journal of Surgery. We've been the American Journal of Surgery, Journal of Physical Surgery, and so on and so forth. The British Medical Journal, the open one, that was the Age paper, and so on. So, preventable problems that we have figured out happen frequently with surgical cases who've died. The largest group of problems is assessment problems, and they can be broken down into delays to surgery, the decision to operate, a different operation would have been better, and a delay in diagnosis. And so they're the negatives. The positives were most surgeons don't lie in their reporting. When we have a second-line assessment and we check the data against what surgeons have reported in the surgical case form, we're up to nearly 1,000 second-line assessments. We found about 2 or 3 cases with the tiniest little detail that is not true. So it shows that the data that we have is quite valid, and most cases have no problems. QASM at present, we're doing a fair number of presentations. We presented to hospitals, the state meetings, the RACS scientific meetings, the specialist society set training, and so on. All sorts of different conferences. Generally it's John or me or Jenny, whoever can present. Now, what I'd like to get a strong message across is that these audits in Queensland and in Australia, all over Australia and SASM, are unique in the world. I went to the NISQIP offices in Chicago 2 years ago, and they had a whole floor in a building as big as this, full of statisticians. They produce fantastic data, but it is not peer-reviewed. It is not assessed. They have trained nursing staff who extract the data. It's good for research, it's good for, but it's old. Our data is up to date, and they don't include any ICU data. The NISAPOD in the UK started off being similar to ours, but is different now. The way they work there, I've visited them in London too. They have a committee of people like you. They decide on an issue like, say, infection that needs improving in surgical care. They develop the evidence, they send guidelines to all the hospitals. They test the hospitals to see how they're going for their infection rates. The ones that are outside the limits, they have more infections than they should have. A team goes to them. They have to explain why their infection rates, and it's a completely different process. But this system that we have in Australia, where every single surgical death has a peer review, is unique. I think it's something you should be very proud of. We're generating a lot of data now. QASM is up to nearly 9,000 cases. Nationally, we're up to about 35,000 cases. We have a lot of data on each of them, and you are all able to use that data for whatever research question you might have. Now, why is this such a popular process? Because of qualified privilege. Qualified privilege is guaranteed participation across the nation. And what do I think of QASM's future? This is nearly the end, you'll be pleased to know. Where we would like to go is perhaps to do the same thing but looking at morbidity rather than just mortality. We would like to have data linkage of demographic information so that surgeons or registrars are not filling out forms with stuff that's already in the databases in the public hospitals. We would like to do special projects with safety and quality departments of hospitals. We would like to have access to Dr. Foster data, but I don't know if that's going to happen. It seems a bit negative at the moment. We need an up-to-date coding system, and perhaps the college is talking about doing something about that using SNOMED. We would like to have a much stronger relationship with AIHW. This is very rich data that we have. It should be accessible and used by as many research groups as possible. We would like to work more strongly with surgeons, collecting, analysing and writing up. So there are limitations. As John North says, the data is there, it is your data. Use it if you wish, publish if you will, and we will assist you. So I'd like to thank Queensland Health for their funding without quibbling ever. Other states have problems we never have. QASM staff for their significant commitment. The steering committee members, the surgeons, this is your project. This is your data. These are your patients. RACS and ANZASM for national support, and I thank you for the invitation to present. Thank you.
Any questions for Therese on QASM, the history, the process?
What's Dr. Foster data?
You've not heard of Dr. Foster?
What's the context?
It's software from University College London, and they've worked out several years ago how getting baseline data from the hospital, how to risk adjust for operations. So, for example, like that NISQEP predictive tools we were looking at before in 2 talks, you can enter the data of your patient, you can work out their risk of death depending on but there would be local data. The advantage that this has is it could be Queensland data or Australian data. The other stuff from NISQEP is American patients. So we would like to be able to do that. So whatever your favourite operation is, we can figure out what the mortality rate is and see how that improves or doesn't improve over the years.
Very good. Thank you very much for coming.
Thank you.